Hello, 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 everyone. It's April 14th, 2025. We are back for our CCS Exam Prep course. And over the last couple of sessions, you guys input your codes in for, I think it was 15 inpatient cases that were assigned to you. I have been looking at what you guys entered to gather some thoughts for kind of like a review session. But while I am working on that in the background, I have decided to begin talking about, officially, I should say, talking about the 5 domains for the CCS exam. Now, in our Blackboard, I did give you a folder that says Domain 1, Coding Knowledge and Skills. And there are 10 folders inside of that. Some of them have some information in it, others don't. And based on our conversations, I will add more content to them. But what we're going to do is talk a little bit more about the CCS exam and tonight focus on domain number 1. Now, I will tell you that usually it takes about 6 hours for us to get through domain number 1. It's really dependent on, well, I should say 3 to 6 hours. So we have 3 hours tonight, and we will see if we will get through it. But it really just depends on how fast you all move. So there's a couple of things that I want to talk about before we get into domain number 1 that I want to use to set the stage. So just to keep myself on track with my timing for tonight, I'm going to set a timer to make sure that after 5 minutes, I'm done talking about this. So one thing that I would encourage you to do is to stay in touch with what AHIMA has on the website. I was on there earlier today, so it's August. It's not August. It's April 14, 2025, and I saw a note on there that said May 1st, 2025. All examinees will be required to have the 2025 manuals. This is nothing new. You all, I've already mentioned that to you. You don't finish until like I think maybe June. I have to look at my phone because the school did ask me to do 2 more weeks. And so I don't even know where my phone is. So I'll have to find my phone and give you the dates. Um, but as usual, everything is recorded. So if you happen to miss, you can pick up the recording. But anyway, I recommend that you stay in tune, stay in touch with the web page, right? So you just go to ahima.org, go to certifications, and stay in touch with what's on this page because I personally don't go to this page. But you, as the examinee, should be fully um, committed to checking this page. And in fact, I would say 12 weeks ago, you guys looked at this page. But I just wanted to remind you of that. Also, on this page, they talk about, let me just go back for a second. where at the bottom of this page where they say view the 2025 list of required code books, right? It pulls up this list here. And so we already know there are 3 coding manuals that you need for this exam. And I should call out for tonight's session, you need to have all 3 manuals at your fingertips. I did tell you all that as it relates to the ICD-10 CM book, you really need to have that hospital version. And on the day of your exam, if you need to borrow someone else's hospital version, I would highly recommend that you do so. And there's a couple of reasons why, and I'll just restate what I said about the reason why you need the ICD-10 CM code book hospitals. Number one, it's a hospital exam. And I think I mentioned I did send HAHIMA an email about this, and so it was probably about 2 weeks ago. So I think I'm going to follow up. So domain number 1, as of May 1st, 2024, these are the 10 tasks that you are expected to be able to perform on the CCS exam. And I think it's very important for you to know that these tasks represent the floor of what you need to know and not the ceiling. And as we start to go through lots of activities tonight, I think it's important that you do a personal analysis of what else you as an individual needs to do some additional research on. As it relates to the code book, the reason I said you need the hospital book is based on number 10, identify major comorbid conditions and comorbid conditions. That's one of the reasons why I say you need to have a hospital book. So you already know you need to borrow one. So that is all. That was a good timing. That is all that I wanted to cover in terms of introduction. Let me just reiterate, there are some activities that you guys have worked on over the last couple of weeks that we will go back to. One of them in particular, root operations, I had to actually manually review that exam because somehow um, it it got all mixed up when the computer was grading it. So anyway, we will continue. So what we're going to do tonight is go through all 10 domains uh, or all 10 tasks, but not in the way that you would expect to go over them. I'm not going to lecture about these 10 tasks because we've been talking about them, right? So the very first task is for you to assign diagnoses and procedure codes based on the provider's documentation in the health record. At this point, you should know that the CCS exam is for hospital inpatient and hospital outpatient, which is why you need all 3 manuals. All right, so we're going to spend a little time focusing on task number 1. And we're going to start with the scenario. The patient was registered for ambulatory surgery due to a skin lesion on the left cheek. The patient underwent excision of a 4 centimeter malignant lesion on the skin of the left cheek. The discharge diagnosis was carcinoma in situ of the skin, left cheek. So something I want to call out here They use the word discharge diagnoses, and I think a lot of times people get confused on that because they're thinking, oh, well, they're talking about inpatient because they said discharge. They're just discharged from the ambulatory surgery status. So, since this is an ambulatory surgery situation, you should know that you would need to assign a CPT code and a diagnosis code for this scenario. And so I'm going to give you 5 minutes to code this scenario. And once you're finished, put your responses in the chat box. I realized that I did not set the timer, but luckily I've been keeping track um, on the computer clock. So you got a few more minutes left for this question. All right. So, as I've said many times during this journey, in a review course, it's not like when you're actually taking a class to learn how to code. We are actually reviewing. And as you continue through this journey, I would highly recommend that you do an inventory of what additional resources you as an individual will need. So, this is an outpatient scenario. So, for the procedure, of course, we would be using CPT. And then for the diagnoses code, we would be using ICD-10-CM, the only option that we have. And for this particular question, you need to know the rules for both code sets because you need to understand how you code the excision of a lesion. And then you need to know about that, what do you call that? Neoplasm table and the whole neoplasm business. So for this scenario, the CPT code is 11644, 11644. And then the diagnosis code is D04.39. D04.39. All right, so we are going to move on to the next question. And for this particular question, the patient was registered for ambulatory surgery and excision of a recurrent ganglion cyst dorsum of the right wrist was performed, and then the diagnosis was a ganglion right cyst. So 5-minute timer is now on. All right. So for the procedure, CPT code is 25112 with the modifier RT, 25112, modifier RT, and then the diagnosis code is M67431. All right, on to the next question. This one is a little longer. So we have a 34-year-old female patient who received a level 4 evaluation and management service. Let me pause for 1 second and talk about something that I like to call a gray area on the exam. So many of you are coding outpatient. I think one or two of you may be coding ED, but just for everyone's general knowledge, evaluation and management from an outpatient facility perspective, the process at arriving at the level is different than when you're coding for the physician. When you're coding for the physician as of January 1st, 2021, you can assign the code based on the complexity of medical decision making or the total time on the date of the encounter. When it comes to the outpatient hospital setting, there is no standard for how we arrive at the level. Some organizations use a severity model. Some organizations have a point system. And I have to be honest in saying that when I took the CCS exam, which was 2006, I didn't even know this. And I was able to attack the question based on the information that was submitted or that was presented on the question. I say that to say that when you're looking at a question and you see something that is just not familiar to you, don't freak out. Just read the question and go from there. So, this particular question, the way that it's worded, you know that the patient is in the emergency department. You know that it's a level 4, so there's no mystery there. In AHIMA's exam prep book, they do present a model that is based on a point system. And again, for me, when I took my exam, I literally used my common sense to arrive at the answer. And so that's my advice to you, because I don't think that they have really clarified what model they're using. But in the review book, they give a question that has a point system. So anyway, the patient complains of skin irritation, fatigue, and severe joint pain. They have a recent history of vacationing in a humid tropical location. She explained that she noticed the development of a hard, round swelling on her upper right thigh some hours after she slapped at a fly. Upon returning home, the swelling became ulcerated, and then she started feeling tired all the time and had really severe joint pain. A sample of the ulcerative lesion was taken and sent to clinical pathology, and dark field examination of the skin sample revealed microscopy, dark field examination of the skin sample via microscopy revealed cutaneous early jaws. On the CCS exam, I don't think that they want you to code pathology. So you don't have to worry about that. Um, so what you do need to code um, is the other services that were provided in the emergency department. So the level 4 evaluation and management service, the sample of the lesion that was taken, so the biopsy, and then the diagnoses. Now, one thing about the biopsy, you don't really know how they got the sample. So, for our purposes today, don't worry about the biopsy. Just code the level 4 emergency department and then the diagnoses of cutaneous early yaws. And I'm not going to even put on the timer because this should be real quick. Oh, you know what? I'll put the timer on just in case. All right, so it looks like everybody is finished. And so for this scenario, the CPT 99284, 99284, and then the diagnosis is A66.2, A66.2. All right, time to go higher. Hopefully you can read this. All right, so diagnoses of ventricular tachycardia, operative procedure, repositioning of a pacemaker electrode. 21 days after the initial insertion of the right ventricular pacing cardioverter defibrillator, the patient began experiencing periods of rapid heartbeat and decreased blood pressure. The patient was taken to surgery to rule out pacemaker malfunction. So let me just pause for a second. This is an outpatient case, and the provider has used the term rule out. When we code outpatient, we can't code rule out. All right. After general anesthesia was administered, the patient was draped and prepped in the usual fashion. Incision was made into the existing pocket. Under fluoroscopic guidance, the pulse generator electrode were removed, examined, and tested. No defects noted. The pocket area flushed. The generator was reinserted into the pocket. Electrode was reattached to the generator, repositioned into the right ventricle, and retested. They closed them up, took them to recovery, tolerated the procedure well, had no other symptoms, and the patient, who was an outpatient, was sent home. So for this case, you need a CPT and a diagnosis, and at the top of the report, the diagnosis was ventricular tachycardia. They took the patient to the OR because they wanted to rule out that there was a malfunction. Timer starts now. All right. So, let's talk about the diagnoses first. Ventricular tachycardia is I-47.20, I-47.20. This code family for ventricular tachycardia, I think, was expanded out about um I, I want to say it was like 5 years ago, where we went from I-47 to all these other options. Okay. Another diagnosis that could be added is Z95.0, which shows that the patient has a pacemaker, which the patient does. All right. So Z95.0. So I-47.20, Z95.0. CPT, CPT, CPT. 33215 with a modifier 58. 33215 with a modifier 58. So, one of the things that I would like for you to do is in your CPT manual, go to the inside cover. So, in your CPT manual, go to the inside cover, and on the right side, look at where it says modifiers approved for hospital outpatient use. Modifiers approved for hospital outpatient use. These modifiers are important because they are for you for the CCS exam. Now, if one day you decide, I think I'm going to take the CCSP exam as well, I personally did it the reverse. I took the CCSP in 2004 and then took the CCS in 2006. But I'm a nerd, so I did take some other exams before, after, during, etc. Anyway, if you're coding for the physician, you would be using those modifiers on the left, 22 to 99. So anyway, modifier 58. Stage or related procedure or service by the same physician or other qualified healthcare professional during the postoperative period. So that's the reason for modifier 58. All right, we got one more question for task number 1. And I know some of you are saying, whew, we didn't do any PCS. But here we go. All right. So a patient was admitted to the hospital, was diagnosed with displacement of the lumbar intervertebral disc, and underwent an open discectomy, resection procedure L1 and L2 with an open spinal fusion using an autologous bone graft. And then it was posterior technique approach, posterior column. So that's all I'm going to say at this moment. And I will set the timer. All right. So for this one, I'm going to just reiterate that this is an inpatient case. And when you're coding on the CCS exam, inpatient, the procedures are going to be with ICD-10 PCS, no CPT. So the diagnoses of the um, displacement of the disc, M51.26, again, M51.26. And then there were two PCS codes. First, 0SG 0071. I'm going to say that again, 0SG 0071. And the second code is sorry, my throat is really really dry today. I've had so much water, you would think that my throat would be would be moist. 0ST20ZZ. 0ST20ZZ. So that first code is the code that is the root operation of fusion, and it's fusion using the autologous bone graft. And then that second code is for the resection procedure. So, and let me make sure I said the number right. 0SG0071. 0SG0071. And so that is 0SG. Did I say the number right? 0SG0071. 0SG0071. Zero SG0071. So fusion of a lumbar vertebral joint with the autologous tissue substitute, and it was L1 and 2. And then the spinal fusion. So 0SG0071. Okay. I want to make sure I read that right. 0SG0071. Okay. Does somebody have anything different? So 0SG, wait 1 second. 0SG1071. So let me look that up. So it was fusion of with an open spinal fusion. So that part, I don't know if I would give that 2 or more joints. With open spinal fusion using an autologous bone graft, posterior technique, approach, posterior column. Yeah, I can send that to somebody else and see if they would come up with 2 or more joints, but I would, it's the fusion of the lumbar joint. So that's just one joint. I don't know if you're confusing the L1 and the L2, but it's the spinal fusion and it's only the lumbar spine. It's not lumbar, thoracic. So I think that that may be where the difference is. But I'll send it to someone else and get their thoughts on it. But those are my thoughts at this time. All right, so let's take a 5-minute break so you can go get some water or something, use the bathroom, and we'll come back. All right, we are back. It is so windy here in Chicago. I feel like we're going to blow away. All right, so the next set of scenarios are about identifying the principal or first listed diagnosis and procedure based on the respective guidelines. So, principal is inpatient, first listed is outpatient. Our first scenario, we got a 12-year-old boy who was seen in the ambulatory surgery center for pain in his right arm. X-rays showed a fracture of the ulna. Patient underwent a closed reduction of the fracture, right proximal ulna, and an elbow to finger cast was applied. What diagnoses and procedure codes should be assigned? Keep in mind this is ambulatory, and so you should be assigning CPT. Oh, something that just came to mind. On the CCS exam, one thing they could try to do to trick you is to give you a multiple choice question. It's outpatient, and they give you PCS codes and CPT codes. So I would just caution you to, excuse me, my throat is so dry. I would caution you to pay attention to if you're coding inpatient or outpatient. All right, I'm going to set the timer. All right, the 5 minutes is up. So for the CPT code 24675, 24675. Now I do see in the chat that one of you has 24670. So what is the difference between 24670 and 24675? And you definitely need the RT. Oh, you guys will appreciate this. I went to the eye doctor last week, so I'm going to be getting some new glasses. I wear contacts, but I'm going to be getting some glasses with some progressive lenses, so I expect to be seeing much better next week. Okay, 24675 includes the manipulation. For those of you who don't know, in the subsection note for the musculoskeletal system, they talk about the word reduction is the manipulation. Okay. Two, let me say that again. 24675 with the modifier RT. Diagnosis code S52.001A, S52.001A. So I see an S52201. What's the difference between 001A in the S52 versus 001A? So S52001A is unspecified fracture of the upper end of the right ulna. And what was the other code? 201A is unspecified fracture of the shaft. So in the scenario, and this is a really good call out here, they say it was the proximal ulna. And so proximal means nearest the point of origin, whereas distal would mean away from the point of origin. So it's the play on words here. All right. Okay, that is all for that one. Let's go on to the next one. Patient is admitted with metastatic carcinoma from the breast to the liver with a previous bilateral mastectomy and no reoccurrence at the primary site. So let me just pause again to just reiterate the importance of you reading and applying those guidelines because they actually talk about this type of scenario in the guidelines. In the progress note of day 3, the physician indicates that the patient now has pneumonia and begins treatment with an antibiotic that will be continued on discharge. So, what is the proper sequencing for this admission? Proper coding and sequencing. And I'm going to start the timer now. So let's start to talk about this case. So the patient is admitted. Um, the patient is admitted with metastatic carcinoma from the breast to the liver, with previous mastectomy and no reoccurrence at the primary site. So we know that per guidelines, breast cancer is a history of, as opposed to a history of. They no longer have the breast cancer. So the secondary site would be the first listed principal diagnoses. Um, so that's Z78.7, Z78.7, which would be the liver cancer. The patient now has pneumonia, so that's a J18.9. The history of breast cancer, personal history, Z85.3. And then we have a code that most people miss, which is the Z90.13, which is an acquired absence of the breast. So let me say those again. C as in Charlie, 78.7, J18.9, Z85.3, and then 290.13. Now, I guess what is helpful on the CCS is that the questions are multiple choice. However, if they throw that sequencing off, if they, excuse me, if they have the codes in a different order, will that throw you off? Now, as it relates to the treatment with the antibiotic, I'm going to, on the break, I'm going to look and see if that is a code. And I think I might have posted this somewhere, but I'm going to double check. If that is one of the codes. Oh, you know what? Actually, I can check right now. Hold on one second. Okay, I'm going to post this somewhere, but in the review guide, it says for inpatient coding, code all procedures that fall in the range of 001 through 10Y. Do not code procedures that fall in the range of 2W0 through HZ9. And then do not code a bunch of other procedures, which I'll put this list somewhere where you can see it. So that's the reason why we didn't pick up the antibiotic. And more than likely in the hospital, that would be picked up by the hospital charge master and not, it would be hard coded as opposed to soft coded. All right, let's go on to the next one. 50-year-old woman with a diagnosis of metastatic ovarian cancer to the pleura has an outpatient thoracoscopic pleural desis performed. What is the correct coding and sequencing? Oh, excuse me. Sorry about that, guys. I'm gonna hit the timer. I think I'm gonna make me some tea while you're doing this one. All right, I am back. So, um, for this particular case, our patient has a diagnosis of metastatic ovarian cancer to the pleura. So, that's important for sequencing. Um, and the patient has an outpatient thoracoscopic pleurodesis. Okay, so now that would ultimately change how you would sequence because according to guidelines, if the um, services that are being rendered today focus on the secondary or the metastatic site, that is what would go first. So codes are in this order: C78.2, C56.9, and then 32650 is the CPT, and I'm going to say them again. C78.2, C56.9, and then 32650. And I don't think the C82 code family has been expanded out to the fifth digit. So it would just be C78.2. All right, next patient. Here, we are only going to do diagnoses: acute respiratory failure, hypertension, and congestive heart failure. Admitted for intubation and ventilation. The patient's heart failure is stable on current medications. What are the correct diagnoses codes and sequencing? So you really want to think about, after study, what is the principal diagnoses, and then put the other ones after. And there is a coding guideline from the cardiovascular system that you'll want to pay close attention to as well. I know some of you can code this without even looking up the numbers because you already know what they are. All right. So, our principal diagnosis is going to be for the respiratory failure because they intubated this patient, put them on a vent, and so they that's the condition established after study. This patient has hypertension and congestive heart failure. There is a coding guideline in a cardiovascular section that says if the patient has um, hypertension, heart failure, um, the ICD-10 CM code set assumes a relationship between the two unless the provider has said that they're not related. So immediately after J96.00, you have I11.0. I11.0. If you guys do something different at work, I would encourage you again to make sure that you're following the guidelines because this exam is based on guidelines and not necessarily what you do at work. So the second code is I11.0. The third code is I50.9 because it says the patient has congestive heart failure. It doesn't tell us anything. Um, it doesn't tell us anything about it, about the heart failure. Now, I see that one of you has Z99.11, which is that dependence on a ventilator. And I think the guidelines state, let me think about this. If the patient has chronic respiratory conditions that necessitate long-term use, we can use that. Um, Somebody who's out of surgery and they require a vent. So let me think about this. Acute respiratory failure that requires a vent. So I could see how you would capture that. Now, well, on the test, it'll be multiple choice. So it won't matter if you have it or not because you'll know. All right. So I guess one key thing here, make sure you're following that guideline about hypertensive heart. Oh, and there's another one. There's the I11 hypertensive heart with heart disease, I12 hypertension with CKD, and then I13 hypertension, CKD, and heart disease. And I work with a group of physician assistants, and so this is something that I'm constantly educating them on, seem like daily. All right, last one for this um, task. A patient was discharged from observation following outpatient surgery with the following diagnoses: posterior subcapsular mature incipient senile cataract right eye, diabetes mellitus, hypertension with treatment for mild acute renal failure. So the patient had, and I think you should pay close attention to this. The patient was discharged from observation following outpatient surgery. So there's a guideline in section 4 of the guidelines about how this sequencing should go. All right, I'm gonna put the timer on. And this is diagnoses only, no procedures. All right. So the patient was discharged from observation following outpatient surgery. So let me pull up the guideline. Okay, I'm trying to pull these guidelines up. They don't want to open up. All right, let's try this again. So this would be guidelines from section 4. Let's see. And I, of course, have the, the version that I recommended that you bind together. All right. So letter A, selection of the first listed diagnoses. Number 2, observation stay. When a patient is admitted for observation for a medical condition, assign the medical condition as the first listed diagnoses. When a patient presents for outpatient surgery and develops complications requiring observation, requiring admission to observation, code the reason for the surgery as the first reported diagnoses, followed by the complications. So, which one does our patient fall under? Observation for a medical condition, or when a patient presents for outpatient surgery and develops complications requiring admission to observation. And you should have these in front of you, but I will put them in the chat. So this is page 111 of the hard copy of the guidelines. This is section 4, outpatient coding guidelines. Letter A, selection of first listed condition. And then number 2, observation stay. So I will give you a moment to ponder on that. So would it be the first guideline that applies or the second one? Okay, it would be the second one. Okay, so if the person had surgery, which diagnoses would be the surgical situation? Which diagnoses would require the patient to have surgery? The cataract. All right. So, um, let me see what numbers you guys have. E1136 and H25041. I10 for the hypertension and N17.9. Okay. So E1136, H25.041, I10, and then the N17.9 for the mild acute renal failure. So one thing that I want to make sure that I overemphasize about AHIMA exams, you got to apply the guidelines. And in a multiple choice situation, you know what they're going to try to do? They're going to try to trick you by giving you all these codes and all different types of order. And you have to just know, like, oh, there's a guideline about that. So if you haven't read the guidelines yet, I highly recommend that you read them at least 5 to 10 times before you take your exam so that you can apply them. All right, I told you it was going to take about 6 hours to do this, and that was definitely spot on because we have only done 2 tasks. And we're going to enter our third one, which it will speed up a tad bit. All right, so our first question during, and this is one that you may not know the answer to. So during a physician encounter, office encounter, a patient underwent T3, T4, and blood glucose laboratory tests, bone density scan, chest x-ray. Well, I think you should know this because you should know this. Provider documented hypothyroidism, diabetes, osteoporosis, chest pain due to a possible hiatal hernia. What diagnosis justifies the medical necessity for T3, T4 blood tests? And I'm pretty sure that I gave you guys a list of blood tests or something, abnormal values or whatever. But so which of those diagnoses would justify the T3, T4 blood tests? You don't need 5 minutes for this one. They got 4 diagnoses. Which one supports the T3, T4 blood test? And this is an example of a test question where you can get the answer quickly and you can get the answer quickly and go on to the next one, right? And have some time for some of the harder ones. All right, so the answer is hypothyroidism. All right, next. Uh-oh. When using both the ICD-10 CM index and the tabular list when assigning codes, what does that result in? And this is a guideline that tells you you got to use both, but what does that result in? And I know many of you use encoders at work, so I will just give you this answer. Using both the index and the tabular list results in accurate coding, because that's what the rules state. All right, next question. When a residual effect is documented after the acute phase of an injury or illness has ended, a code for the blank condition is sequenced first. This is another guideline. And as I mentioned earlier, today, this is an opportunity for you to see what areas you still need to work on. And according to the guidelines, the residual condition is sequenced first. This is like in the first part of the guidelines. All right. Next question. When the provider documents the same condition as acute or subacute and chronic during an encounter, and the ICD-10 CM index contains sub-entries for each, what do you do? This is straight from the guidelines. This one is straight from the guidelines, and basically it says this is like general coding guidelines. So when the provider documents the same condition as acute um, or subacute and chronic during an encounter, and the ICD-10 CM index has entries for both, you code both, but sequence the acute one first. All righty, one more. We're moving right along here. When a related definitive diagnosis has not been established or confirmed by the provider for an outpatient or physician office encounter, codes are assigned that reflects what? Codes are assigned for the signs and symptoms. That is correct. That is correct. All right, we are going on to task number 4. Attach. Let me see, do they still say attach? They changed the word the last year. So CPT modifiers to outpatient procedures. And earlier today, I drew your attention to these modifiers, and I want to just reiterate this is a hospital exam, so you are not coding for the physician, you are coding for the outpatient hospital. So let's look at a couple of options, scenarios. Carcinoma of multiple overlapping sites of the bladder. Patient had a diagnostic cystoscopy and a transurethral fulguration of bladder lesions over the dome and posterior wall were completed. A biopsy was taken of the lesion in the lateral wall. What modifier would be added to the biopsy? And 59 is correct. And this was the key here. So they had a diagnostic cystoscopy and transurethral fulguration of bladder lesions over the dome and the posterior wall. Then they took a biopsy of a lesion in the lateral wall. So it's separate and distinct. 59. All right, here's another one. A bronchoscopy with multiple biopsies of the left bronchus was completed and revealed adenocarcinoma. What, if any, modifiers should be added by the facility for that procedure? And I had an opportunity to speak with someone today who took the exam earlier today. And one of the things he said, it was a guy, he said that he remembered me saying this and it literally stuck with him that in the practice session like we're doing now, you don't know it, look it up, because on the day of the exam, there is no Google for you to try to figure out the answer. You either know it or you don't know it. And the clock keeps on ticking. So, um, if you look up a bronchoscopy, if you look up the CPT code for um, bronchoscopy with biopsy, is the word biopsy in um, is the word biopsy with a S in parentheses? Look that up real quick. Look up bronchoscopy in the CPT manual with biopsy. Gonna be something like 316 something. All right. So since it has the letter S, that means one biopsy, multiple biopsies. You can't put a modifier on that code because the code includes multiple biopsies. That makes sense? Okay. Next up, a patient has a blepharoplasty of the left upper eyelid. What modifiers should be used? Blepharoplasty of the left upper eyelid. And as a reminder, the modifiers are in the inside cover of your CPT manual. And left upper eyelid. Um, in your CPT manual, inside cover, lower right hand corner, do you see another set of modifiers? They are like, yeah, so it wouldn't be LT, it would be E1, not LT. It would be E1. All right. I think we got one more. Yep. Facilities may use X modifier in place of which modifier? Now, you guys, I don't know. Well, we'll see. I don't want to say you don't know this, but if you go to Appendix A, the X modifiers are there. Yep, it is in place of 59. So X, I don't even know those X's. XP, XS, something like that. All right. Um, let's take a 5-minute break before we start this. Uh-oh. All right, so we're going to go on to task number 5. The first couple of ones are really short, then the last one is a little longer, and that will be all that we'll do tonight. On Wednesday, we will continue with domain 5 and domain 5 with domain 1, and I would encourage you for the rest of this domain that you look at the resources that have been provided to you for the other 5 tasks that we're going to look at on Wednesday. It is my hope on Wednesday that we get through the remaining 5 tasks, and then I want to do some more just selecting the principal diagnoses only scenarios, not necessarily the code, but just the word, just for more practice. All right, so task 5, determine the appropriate sequencing of diagnoses and procedure codes based on the scenario. So here, you don't have to give a code, just give a word. A female patient with hematochezia presents to the hospital outpatient surgery department for a colonoscopy, but the procedure was not performed due to elevated blood pressure. What is the first listed diagnoses? And in case you're wondering, yes, there is a guideline for this. And again, no code is needed, just the word of what is the first listed diagnoses. All right, it is the hematochezia. That would be the first listed diagnoses per guidelines. All right, next patient. Patient takes Coumadin as prescribed and correctly administered. However, the patient develops hematuria secondary to Coumadin use. What would be the correct coding assignment for this case? And again, no codes needed, just the words of what you would code. And there is a guideline, right? When you're coding adverse effects versus poisoning. And what would the adverse effect be? So, yes, the hematuria is the adverse effect. And so that would, in fact, be sequenced first. And then you would have the T code for the drug, which would be the Coumadin. All right, a patient is admitted with abdominal pain. Discharge summary says pancreatitis versus non-calculous cholecystitis. Both are equally treated. Based on coding guidelines, which one would be sequenced first? And it is either could be sequenced first. According to the guidelines section 2, when two diagnoses equally meet the definition of principal, either could be sequenced first. All right. A 34-year-old woman delivered a live born term baby boy, 39 weeks with microsomia. She had a hemorrhage following low forceps delivery with episiotomy, but prior to the expulsion of the placenta. And for this one, we do need codes. And I guess I lied. We need codes for the last two. This is inpatient, so you will need to have the PCS codes. And report the diagnoses first, followed by the PCS codes. I better put the timer on for this one. All right. So as you guys are looking at this one, sequencing is definitely important. So things like weeks of gestation, outcome of delivery, those are secondary diagnoses only. And when you're coding a mommy, um, you need to code after study what caused mom to have I had to see what this little boy, I couldn't see. So mom did have hemorrhage following a low forceps. But mom also had microsomia, which means that the baby was uh, kind of big. So your code should be 036 80x0 036 80x0 067.9, that's the hemorrhage. Outcome of delivery, one baby, Z370. Um, and actually, I will put the 067.9 first. So let me start over. 067.9 first. 036 point. 1 second, because I gotta put my glasses back on. This is just what you call denial. So let me start over now that I have my glasses on. 067.9 first. 036.63XO, 63XO. Then the outcome of delivery, one baby, Z37.0, 39 weeks, Z3A.39. Then you want to code the delivery, which is 10D07Z3. Let me say it again. 10D07Z3. And then the episiotomy, 0W8NXZZ. 0W8NXZZ. So let me say them all over again just to make sure I got them all. So 067.9, 036.63XO, Z37.0 is the outcome of delivery, Z3A.39, 39 weeks gestation, 10D07Z3 is for the low forceps delivery, episiotomy, 0W8NXZZ. I would highly encourage you, and again, we don't know what type of cases are going to be on this exam, but that book that I told you about, the ICD-10 CM coding handbook, I definitely would I would practice with that book. All right, and the last one for tonight. We got a 30-year-old patient with AIDS, asymptomatic at this time, is admitted for repair of a hernia. Procedure was performed, was a right indirect herniorrhaphy via open approach. This is another inpatient case, so you do need PCS. All right. So when the doctor says the patient has AIDS versus HIV, if he says HIV, that's Z21. If he says AIDS, which is the disease, that's B20. I think what threw you guys off was that asymptomatic at the time. But again, if they say AIDS, that's B20. If it's HIV, the infection versus the disease. So infection is Z21, AIDS is B20. All right. So, but the B20 was not first listed because it has nothing to do with the hernia, which was K40.90. And this was a true repair. And that is going to be 0. I and O is not used in PCS. 0YQ50ZZ. 0YQ50ZZ. And as I stated, it takes us 6 hours to get through domain number 1. And in order for you guys to be prepared for Wednesday, let me just reiterate that what we're doing on Wednesday is going to be task 6 through 10. So it's going to be a little bit more heavy duty. So make sure you are ready. If you have not read the POA guidelines, you should read them. If you have not looked at the information that I provided you on NCCI, DRG, APC, MCC, CC, you should look at that. And it is all available in Blackboard under domain 1. Yeah, available in Blackboard on domain number 1. In fact, I would say 4 of the 5 tasks that we have, there is information there for you. So I would highly recommend that you take a look at that information. And again, we're going to go through the 5 tasks, and then it is my desire that we can do some additional principal diagnoses, scenarios where you would just select the words, because I think that you need more practice with that, just to be sure. And that's all I got for today. Hope you guys have a good evening, and see you on Wednesday.